preeclampsia, which isn't the sexiest topic, but I think it's important to know about. And even though, you know, we have gynecologists who are here on site, not every hospital does, and the time that it takes for them to come down to evaluate these patients, we should already be starting the management of what we should do. And keep us on our differential when we see our patients who have high blood pressure, which is pretty much like everyone who's pregnant, okay? So we're going to go through a case. I'm going to talk about what preeclampsia is and how it kind of forms around the time that we see it. Let's talk about the preeclampsia, the pathophysiology, what we should do as ER physicians, our management, and some new studies on what people are thinking about to help prevent it in patients who are at high risk. So let's meet our patient. So we have a 28-year-old. She doesn't have any medical problems. She's 21 weeks pregnant. She hasn't had any prenatal care, but she's coming in because she's got this headache for 4 to 5 days, and she's like, "Doc, I have migraine, so I thought it was a migraine. I've been taking some Tylenol, but it's not really going away, and now I'm having just a little bit of some blurry vision, like I'm seeing some spots." And then you go through her review of systems, and besides her urinating a lot, which she's like, "Oh, it's because of the baby, nothing really else is going on," and her significant social history is just that she's a smoker, but as soon as she got the positive pregnancy test, she stopped smoking. So you order some labs, you know, the usual stuff that you get when someone's pregnant and they're having some symptoms, and you find that her creatinine's elevated to 2.1. She doesn't have any history of any kidney dysfunction. She's got an elevated AST and ALT, and her UA shows that she's got 2+ proteinuria. Still waiting for the culture. Oh yeah, forgot to give you her vitals. So her vitals, so now you're doing the exam, and when you're examining her, she's hypertensive to like 162/103. She's not tachycardic, she's afebrile. She looks well, but she's like a little bit uncomfortable. Her heart and lungs sound good. And in her belly, she's got a little bit of right upper quadrant tenderness, but it's voluntary, no guarding, no rebound, and she's talking through it, so it's not that bad. So what do you do now? And you're thinking, you know, you're a second-year resident, you're like, "Oh, this person's probably got preeclampsia, let me call gynecology." And then you're like, "Wait, I want to make sure I really know what I'm talking about, and I sound smart, because they're just going to slam me and be like, 'Why are you calling us? It's the middle of the night.'" So what is preeclampsia? So what I want to add to the definition that we probably already know is, we have this definition of usually if you have new onset systolic blood pressure above 140/90, between 20 weeks and until 6 to 8 weeks postpartum. But you should also include patients who already have pre-existing hypertension who are presenting with these new symptoms, which are proteinuria, new onset visual or cerebral disturbances, which can be like photopsia, scotoma, severe headaches, altered mental status. You can have severe or persistent right upper quadrant tenderness that's unresponsive to measurement, elevated LFTs that are upper limits of 2 times normal, less thrombocytopenia of less than 100,000, renal insufficiency, which is a creatinine of just above 1.1, which is basically just the upper limit of normal. It's not that there's that much leeway, or any signs of pulmonary edema, so if the person has respiratory distress, they're feeling shortness of breath, or they're having any trouble breathing, or decreased exercise tolerance. So what's going on inside the placenta? So in normal pregnancies, the cytotrophoblast cells of the developing placenta, they usually are migrating into the decidua and other parts of the myometrium, including the muscular tunica media of the maternal spiral arteries, which are the end branches of the uterine arteries. So around the time of 18 to 20 weeks, these arteries undergo a transformation where they go from these small, really muscular arteries into these larger capacitance, lower resistance arteries. So usually in preeclampsia, there's an issue with this transformation, this transition that's supposed to happen. So the 3 things that have been studied are that there likely is an increase of the soluble FMS-like tyrosine kinase, and when this tyrosine kinase increases, it binds to VEGF as well as the placental growth factor, which decreases that. When you have less of that, you don't have that change where you have the vasodilation of these arteries. Another one is that we think that there's a decrease in the endothelial nitric oxide synthase, and that's what produces the nitric oxide. So if you don't have nitric oxide being produced, you also don't have this vasodilation of the arterial bed, which leads to hypertension, and it can lead to vasoconstriction of a lot of your end organs, like renal vasoconstriction and the vascular bed of the brain, the lungs, and the liver. The last one is that we think that there also might be an overexpression of placental and renal toll-like receptor 4, and that can lead to an increase of these inflammatory cytokines and cause placental and renal dysfunction. So usually when we think of preeclampsia, everyone says, you know, the cure is delivery. And the reason for this is that the placenta is what's causing a lot of this to happen. However, sometimes it can last for up to 6 to 8 weeks because there might be a delayed clearance of these anti-angiogenic factors, and that can cause people to still have preeclampsia after the placenta has been delivered. But usually it's more rare after the delivery of the placenta, but you should still keep it on mind. So how do we identify it once we have a patient that we think might have preeclampsia? So you're going to do the lab. So, oh, Bradley's hand up, sorry. So this is, you can pass this around, just like. So this is the California toolkit. It's what ACOG recommends as a measure for kind of the pathway of identifying preeclampsia. And what I want you guys to take note of is that if you have borderline blood pressure and you have new onset proteinuria, so if you just have above 140/90, you should still consider atypical preeclampsia and send off the labs, even if you're not getting that 160/90 that we think of the typical number. So if a person has this new onset hypertension, you're going to get the protein, the UA, look for the 2+ protein, or as they define it, it's usually a 0.3 in a 0.3 grams in 24-hour specimen, or a protein to creatinine ratio greater than 0.3 mg/ml in a random sample. But I think the easiest for us in the ED is just getting a UA and getting the 2+. So even if you don't have the new onset proteinuria, you should still check for the persistent, like the thrombocytopenia, the elevated LFTs, the creatinine, and something that we don't usually get, well, I don't usually get, is adding LDH to our basic workup of these patients. And if you have elevated LDH, that's also one of the factors. If you don't have any of the abnormal labs, but you still have something like persistent headache or visual changes or abdominal pain, you should still treat this patient as having preeclampsia. So what that means is if they're greater than 37 weeks, you're going to be calling in OB. If you're at a facility that doesn't have a labor and delivery emergency room to help deliver, or if they're less than 34 weeks and you're in the situation, you're going to transfer them to a tertiary care center. So, like I said, delivery is the only definitive cure, but the main thing that we want to do besides the strict blood pressure control is you also want to prevent seizures. So magnesium sulfate, I know when we're in med school, it's like the hypertensive mothers love nifedipine, and they always put magnesium in this group of medications for antihypertensives, but magnesium actually is not recommended as an antihypertensive agent, but it's a drug of choice for the seizure prophylaxis. You shouldn't wait to give magnesium while you're waiting for the labs to kind of define whether or not this person has preeclampsia. You should just give it. And the dosing for it is 4 to 6 grams IV over 20 to 30 minutes, followed by 1 to 2 grams per hour continuous for 24 hours after delivery. If this person doesn't have an IV, or if they're a difficult stick or they're having other issues, you can start by just giving it to them IM. It's 10 grams. Loading 5 grams in each buttock, and then you could 5 grams every 4 hours. But I'm assuming by then you'll have had the IV put in. But don't delay by trying to get like a sono if you're having trouble, or if you need help, just order the meds, tell the nurse to give it IM, and then kind of ask for help if you're having trouble getting an IV. So the strict blood pressure control, there's 3 main medications that are recommended. It's hydralazine, labetalol, and there have recently been studies on oral nifedipine for patients who either are refusing IVs or are difficult sticks as well. So Let's start with hydralazine. So this is kind of like a timeline of what you should do when you first start with giving hydralazine. So the patient comes in, time of arrival, they're pregnant, they're 21 weeks, they have this nuance of hypertension. The first start is you either give 5 or 10 grams IV push over 2 minutes, then you wait 20 minutes, you recheck, you give another 10 grams IV push, you wait additional 20 minutes, so at this time you're at 40 from the start, you increase to 20, and then at 50 minutes, if you're still high, you give 40 milligrams IV push. At this point, you're consulting ICU, OB-GYN, and maternal fetal medicine, which I know that, I don't know if they're on call, but I know that there is an attending who follows the patients during the day, so as long as they're involved, I'm sure GYN will get them involved. So for labetalol, similar, you're starting with 20 initially, then going to 40, 80, and after the 80, they're recommending switching to hydralazine IV push if they're still high, and then you go into calling ICU, admitting, or transferring depending on where you are. So the nifedipine, which is one that's less studied for patients who you can't have IV access on, you just give them 10 milligrams PO, and then you kind of increase to 20, 20, 20, and at that point you're switching to the IV medications. I didn't find any studies that started with the nifedipine initially just to give it and then transition to the IV if there's a change in the dose, but I think that you could probably just give the first dose of nifedipine and then if it's not working, just switch to any of the other algorithms. See if that helps. So, okay.
The other thing you can do, if none of them are working, the drug I've always found that nowadays works great is in the cardipine. You get that IV.
Yeah.
PO, nifedipine is not working, not available, and the other two for some reason are not working or contraindicated. Especially with hydralazine, they're going to get tachycardia, so just be wary of that.
Yeah.
And with the labetalol, they may get bradycardics, so be aware that if they have asthma, they may start to wheeze. You don't want to use it if they have acute asthma.
Yeah, exactly. So it's important to get a good history when choosing between these medications to know what patient is the best. And like Dr. G was saying, you can always transition them to like an ecardipine, or if they need to be on a drip or something, that's usually the drip of choice. So how do we prevent preeclampsia? So the mainstay, if you don't get pregnant, if someone has a high risk, is going to prevent them from getting preeclampsia. But if they are actively trying to get pregnant, or if they're already pregnant, there have been some new studies and trials. So first is aspirin. This was a pretty big study that came out last year, and it was a systemic review and meta-analysis. They had close to 19,000 patients, and they were studying whether there was a reduction in preterm and term preeclampsia when aspirin was initiated. So they found in their studies, all the patients were given aspirin at a medium dose, so over 100 milligrams, not the baby aspirin. And they found that aspirin reduces the risk of preeclampsia, of preterm preeclampsia, but not term preeclampsia when it's initiated before 16 weeks of gestation at a daily dose of greater than 100. So currently ACOG is recommending aspirin on their guidelines, but they are recommending low-dose aspirin as prophylaxis for women with high-risk preeclampsia, either having multi-fetal gestation, a history of preeclampsia, or a history of renal disease, autoimmune disease, type 1 or type 2 diabetes, which is a lot of our patients, and chronic hypertension. So I couldn't find, I'm sure that they had the study, and I probably just was having trouble finding it, but I couldn't find the study that was suggesting it with the 81. But that's something to look into.
When you give this, did you stop it for the third trimester? Or?
I think that they were giving it throughout, it's continued daily until delivery.
Until delivery?
Yeah. That's on their, the ACOG thing.
Yeah.
Are there any side effects for community?
Yeah, renal acidosis.
Yeah.
I'm curious if the low dose, because remember NSAIDs and ductal closure
Yeah.
was a concern. So I'm curious if the low dose kind of mitigates that.
Hundreds and stuff, yeah. Because I think it would be kind of risky to recommend
It's also make it liquid.
yeah, which would make it scary for if there's any complications that could see. I don't think that it's given regularly, but this was. So another thing is diet and weight loss. So this was another meta-analysis in women who were either randomized to diet or exercise, and it showed that there wasn't really any significant risk of preeclampsia or hypertensive disorders in pregnancy, but it did significantly lower gestational weight, which we kind of already know that obesity leads to increased gestational weight. This is for calcium supplementation. So this was kind of interesting. So this was another meta-analysis that had about 29,000 patients, and they were giving calcium supplementation in both high, moderate, and low doses, and they found that it helped prevent preeclampsia in all three. However, for gestational hypertension, only the high dose and the moderate dose were associated with having a statistical significance in reducing the risk of gestational hypertension. And then this is vitamin D. So, a lot of literature states that vitamin D can play an anti-inflammatory factor. However, this study in the systematic review showed that there was no independent effect of vitamin D supplementation in preventing preeclampsia. And that's pretty much it. So basically, like the patient that we had, she was started on labetalol. Her blood pressure was pretty controlled. She was admitted upstairs, and then they continued the management. I think that mom and baby ended up okay.
And the big thing is be aggressive with your magnesium. That really is. And you can do that until you follow the reflexes. If the reflexes are hyper, or you can keep giving it until they really are becoming flaccid and you back off if you need to.
I mean, Nidhi mentioned it, but remember, just that postpartum, it can be up to 8 weeks. I mean, the definition of preeclampsia is after 20 weeks, so in a lot of practices, ours included, you're not going to see these patients, right? They're going to go straight up to OP triage, but you're going to see the postpartum patients. So we see hypertension all the time, so don't poo-poo it when they're 6 to 8 weeks postpartum. You have to pay attention to that because they can have eclampsia to that point. All right, let's take 5 minutes.
Oh, it was